We have this incredibly bloated financial sector. It's a phony crisis. They don't have to be cuts. We know how to get out of a Great Depression. You spend money. If we take a look at the typical worker, they're not doing fine.
Hi, I'm Dean Baker. I'm your host on Mostly Economics. Today we have with us John Schmitt, who's currently a research associate at the Center for Economic and Policy Research. He's had a long career with, certainly our own think tank, the Economic Policy Institute, and other think tanks around DC. I won't go through all of that. I'll just say he's also an old friend, so I'm very happy to have him here. So thanks for joining us.
Very happy to be here. Thanks, Dean.
So what we wanted to talk about today, John has worked on 3 recent papers with a research associate at the Center for Economic and Policy Research, Emma Churchin, that look at healthcare and specifically healthcare and workers. And I'll just say, because people think whatever they think, but this was done before Donald Trump was elected president, before we knew he was running, but before we knew he was going to be in the White House. So this is about finding out who has healthcare, what sort of healthcare workers have. So it's not about finding bad news about Donald Trump that you could decide for yourself. It's about finding who has healthcare and how do workers get healthcare. So let's start by just saying what you see as your main findings from these papers.
Well, even before the findings, just to talk a little bit about the motivation and expand on what you were saying. The motivation I think that got Emma and I thinking about this is that workers are the group in the U.S. Economy that are the least likely to have health insurance, which is a little bit strange. So if you think about it, if you're 65 or older, you are eligible for Medicare, which is a program started in the 1960s to provide health insurance for the elderly. So if you're working, you're not working, if you're 65 or older, you're basically in a situation of universal coverage. Maybe 1% or so of people of that age range don't have insurance. If you look at the other end, you look at people from 0 to 18, kids, they generally have coverage through their parents, and they also benefit a lot from the Medicaid program, which is the other program started in the 1960s to help people get health insurance. It was focused on families with low incomes. They're still in a situation where there's not universal coverage, which is a shame. And we have maybe 6, 7, 8% of kids still don't have coverage at all. But compared to workers who are the group of people between the ages of 18 and 64, too old for kids care kind of things and too young for the Medicare, that group has about 10% over the last few years of workers that don't have any health insurance at all. So we wanted to explore how it was that these folks didn't have coverage, and when they do have coverage, how is it that they do get their coverage? So that, I think, is the motivation that we started with.
The point about 10% of workers not having, first of all, just to give people the numbers here, we have roughly 160 million workers. So you're talking about 16 million people. So it's good to say 90% of workers have coverage, but 10% don't. So that's a big deal. But there's another point, and this is kind of striking, that because it obviously came up in the debate over Donald Trump's one big bill, that one beautiful bill, where you had a number of people, including people, cabinet officers, who were saying, well, if they get a job, don't worry about people being thrown off Medicaid. If they get a job, they'll have health insurance. And the point here is, obviously, that's not true. 10% is a substantial number. And again, if we think of, the less skilled, lower paid, however you want to define that, because most of the people are on Medicaid now, they're not earning they wouldn't be earning 80, 100,000 a year jobs. These are, they'll be working in a fast food restaurant or, whatever you might think of as being a lower paid position. And a lot of those don't offer healthcare. So when you save 10% for the workforce as a whole, if you're talking about someone who's a marginal worker, they're getting Medicaid, maybe they'll be thrown off by the changes in the bill. Of course, we don't know that, but some obviously will. And if they are able to find a job, there's a strong likelihood that job will not provide health insurance.
Yeah.
So, again, that was just striking that you had so many people in the policy debate who seemed ignorant of that.
Yeah, and I think just to pile on there, when you look at the 16 million or so people that don't have workers, that don't have health insurance, 10 million of them actually work full-time hours, 50 or more weeks a year. These are not people who are floating in and out of the labor force who don't have a strong attachment. These are people who are working very hard in their majority in terms of hours worked and weeks throughout the year. We have a big hole, we have a big gap in our health insurance system when it comes to workers. And it's gotten much better since before the ACA, the Affordable Care Act. And I don't think the Affordable Care Act was some panacea that solved all our problems. We still have obviously a long way to go, but I think it's important also to recognize that if you look before and after the ACA, coverage has improved across the board for a lot of the groups. And a lot of what we're seeing right now in the public debate and in the legislative debate that's just recently taken place is ratcheting back on a lot of the progress that's been made so far. It's a very difficult situation.
So let's talk a little bit about what your findings were about where workers get healthcare coverage. So we do have 90%, again, so whether you want to, I shouldn't make a joke of this, 10% not having healthcare coverage is a bad story, but again, the 90% that do, where do they get their coverage from?
So I'm going to do percentages of the 100%. So 10% are people who aren't covered at all. But if you look at the single most important source of health insurance for workers, not surprisingly, is employer-provided health insurance. It's about 70%. And when I'm quoting these numbers, they're basically taking an average over about the last 6 or so years, not up including the current year because we don't have the data yet, trying to deal with the averages across things like the pandemic, before the pandemic, after the pandemic. So I think it gives us a little bit of a better idea. It's about 70% of employers, of workers get their insurance through their employer. And that's, obviously varies a lot in terms of how much people pay, in terms of premiums, equality, but it's the core of the way we provide health insurance to workers. What I think is most interesting is that, at least in the current context, in the current debate, is that 10% of workers in the United States already get their health insurance through Medicaid, which, as I said before, is a program that's aimed at low income families. So these are workers who are almost by definition working poor. So we already have a program in place that does that. And unfortunately, what we are talking about doing right now with the One Big Beautiful Bill is eliminating cutting back a lot on the ability of Medicaid to provide health insurance to workers. It's criminal in the current context, I think.
Let me ask you something just to clarify, and I should have raised this before, but when we talk about these numbers, who has insurance, who doesn't, this is a snapshot, right? So I'm trying to distinguish between, we're looking, it's, July 2025, we're asking who has insurance now, as opposed to look year round 2025, because again, it's been a while since I looked at the data on this, but there's a lot of people, particularly among this group, that they have healthcare insurance for 2, 3, 4 months, and then they go without it for 2 months because they've lost a job or for whatever reason, maybe it's a bureaucratic mess up. They were getting it on Medicaid and now, they're told, oh, you're not getting it. And then they're able to get it back because it was a mess up, but this is a snapshot, right? This isn't year round.
It's even worse than what you're saying. One way that the data are collected is exactly as you say. They ask this month in March of 2023 or 2024, do you have insurance this month? We are actually using the data that is from that same survey. It's a government survey that comes out that is implemented in the spring of every year, generally in March. And the two questions they ask, one is, do you have insurance this month? The other question is they ask, for the entire preceding calendar year, did you have insurance or not? So when I say 10% of workers did not have health insurance, I am using the numbers that say during any period at all in the preceding 12 months, they had no health insurance. So these are very serious lack of access to health insurance. On top, over and above that, are the folks that you're talking about, which are people who might cycle in and out of health insurance because they changed a job, because their spouse who they had health insurance through lost their job, and therefore they don't have employer-provided health insurance. And again, I should be clear, the definitions are all super complicated, but when I'm talking about employer-sponsored health insurance, could be that you're getting your employer-sponsored health insurance through your own employer, could be through your spouse, or in part, thanks to the ACA, you could be getting it through your parents if you're under the age of 26. So it's it's a mess. The whole thing is very, very complicated, and that's one of the main points that we try to make in some of our other more recent research. Just it's a very complicated maze. It's really difficult to navigate. But we're quoting here probably the worst set of numbers that you can imagine, which is these are people who did not have any health insurance through any source for a 12-month period in a row, and they're working.
That's striking, because I'm glad you clarified that, because I personally misunderstood it. I was thinking this is a snapshot story, and it's bad enough for a snapshot story, but the point is, if any point during the year, that means that's a pretty bad story. So again, getting back to this point, we have a lot of people that go in and out. They're covered for 4 months, they're out for 2 months or whatever, then they come back on, and that is a really big deal, because again, most of us are reasonably healthy most of the time. But let's carry through that scenario. So I'm insured July, August, September, then I lose my job, whatever happens, in October and November, I'm not insured. Now, with luck, I get another job, I'm covered under my spouse, whatever it might be. So, becoming January, I'm insured again. But what if I get sick during that period? Then I probably don't get the other job. So it's, again, if we think of what insurance is supposed to do, that's a really, really serious problem. So again, most of us, we'd have that 2-month period. Maybe we have some minor bills, it's bad news and everything, but, we could deal with that. But if you get a serious illness, or maybe you're in an accident, you get hit by a car or something, you're not going to get that other job. So it really matters that you're without insurance for that 2 months, because you're very vulnerable during that period. And again, most people, they'll get through it and they'll get their insurance again. But that is a big deal, that you have to go through that period where, in effect, you're at serious risk.
Yeah. No, and of course we have the COBRA program, which allows you to continue your employer-provided health insurance, and that is available to everybody that is qualified to have that kind of insurance. But the problem, of course, is that it can be enormously expensive. So if you're a low or even middle-wage worker, you might not have the $1,000 a month or the $1,500 or $1,800 a month to cover your family, or even just a few $100s a month to cover yourself, if that's all it is, especially if you're young. So it's a very, very imperfect system. It leaves people in a difficult situation precisely when they might need it the most.
Yeah, just to explain COBRA, and I'm forgetting exactly what the acronym stands for, but this dates back, I think, to the 90s, maybe even further back. But it essentially requires that a employer, if someone leaves, even if they're fired, they could stay on their coverage. I believe it's 6 months. They may have changed that, but I believe it's for a 6-month period. But you have to pick up the premium, and they could even charge you something on top of the ordinary premium for basically administrative cost. And it's extremely expensive. I've known, my wife's been this. I've known a number of people who've changed jobs. I literally don't know a single person that ever took up COBRA insurance. I'm sure a lot of people have, across the country, people do it, but it is extremely expensive. So even for many very middle income people, it's just not a very good option. So.
Yeah, Emma Kirchen and I, who've been doing this work, our next project in this series is going to be looking at how much people pay in premiums and how much workers pay in premiums and how much workers pay in out-of-pocket expenditures. And you can see a big jump as soon as people that do choose to be on the COBRA plan have to take over the full payment that their employer was presumably helping to share with before. We're talking thousands and thousands of dollars a year. And for people that might make $40,000 or $80,000 a year, that could be an enormous portion of their after-tax income. So,
yeah. So let me ask, you looked into this somewhat. How do you see it's the one big beautiful bill, the items in it? How do you see that affecting coverage for workers, and I guess I should say non-workers?
well, as you said at the beginning, we started to do this work before all of these changes went into place, and we were well along and didn't want to sort of jump ship and ignore kind of the broader context because in part so many good people were doing great research. So there's been some good analysis so far that I think is worth particularly for your viewers, listeners to think about. There's a very good analysis by the Congressional Budget Office. There's a good analysis by KFF, which I think used to be called the Kaiser Family Foundation. Yeah. And they find some, consistently terrible numbers as to what the likely impact of these bills are. I don't want to exactly misrepresent the numbers, but on the order of about 17 million people are going to lose coverage between now and 2034 in both of their analyses of what's going on. And that's for a couple of reasons. One, the ACA had some very generous tax breaks that were put in place during the COVID period in order to allow people to get coverage through the ACA. Really, it dramatically reduced the cost of getting private insurance through the ACA marketplaces. That is scheduled to end at the end of this year, and the One Big Beautiful Bill does nothing to extend that. So a lot of people are going to be losing coverage through the ACA when their costs go up enormously.
I just wanted to step back for a second because
Sure.
this is one of the things people have heard my diatribes. That Biden did, you could go back, look at his record. Obviously, it's mixed things, so you could complain about he didn't do more. But one of the things he did do was he made the subsidies in the Affordable Care Act exchanges far more generous, particularly at the, I shouldn't say higher end, but the higher end of eligibility. So we're still talking about people earning 60 or 70,000. So none of these are high income people, but these were people that, largely were above the cutoffs for subsidies. And he made those much more generous so that, say, a couple with an income of 70,000, it was now very affordable for them to get insurance through the exchange. But that's what John is saying is going to end as of, I guess, January 1st.
Yeah, and the impact of that is really hard to imagine. I'm just looking at the numbers right now. If you go back to 2019, 2020, about 11.5 million people were on the ACA marketplace coverage. And that number has gone more than doubles. Now there's 20, in the most recent data, more than 24 million people are now in that very short period of time so it's more than doubled the coverage. And that is almost everybody attributes that to exactly the generosity of the tax breaks that people are getting, the subsidies that they're getting to go on. And when they take that away, it's a dual problem. First, some people are going to lose, many people are going to lose their coverage. But the other thing is that the subsidies brought in some healthier people who before were deciding to not get health insurance because they were just going to roll the dice. And then when it became cheap, they thought, well, this is a useful thing. Now, obviously, when you have a lot of healthy people in and they're paying contributions, it helps to keep the system working much better than when the healthiest people leaving only the people who have the most health problems. So it's a disaster from any point of view for the individuals and for the system more broadly.
Yeah, just to go further at that point, because I remember when we were first debating Obamacare back in 2009, 2010, one of the concerns is always a skewing, which, this is an inevitable problem with an insurance market that you can get skewing. And the issue here is that the people who have serious health issues, they're going to try and get insurance. And in fact, that was one of the main problems that Obamacare sought to remedy, that you can no longer discriminate against people based on their health conditions. And it's one of these things, I'm sure you've had similar conversations with younger people that they look at you strangely like, what? They could deny you insurance if you have cancer? And before Obamacare, they absolutely could. They could either deny you insurance or they say, oh, sure, we'll insure you, but it'll just be $60,000 a year. That was the norm, so that was a regular pattern. So Obamacare said, no, you can no longer discriminate against people based on their health condition. But the problem or the concern that everyone recognized at the time was that, okay, so then you'll get people who are very healthy because, insurance is going to be more expensive, obviously, if they have to cover less healthy people. So you'll have people who are generally pretty healthy and they'll say, well, I'll roll the dice, I'll take my chances. And if that gets too far, you have a pool of nothing but unhealthy people, and then it's very expensive. So that was the risk. And it turned out, obviously that has been a problem, but it's not been nearly the problem that people feared. And again, an advantage, as John mentioned, advantage of the expanded subsidies that Biden put in place was that you brought a lot more relatively healthy people into the program.
Yeah. The whole dynamic here is so complicated and so unfortunate. One of the issues that we try to highlight in the work we've been doing is that if you're a worker and you're trying to get health insurance, you can get it through your employer, and then there are a lot of other, if they offer it and if it's affordable. And outside of that very straightforward and not so straightforward option, there's just a million different ways that you have to kind of navigate this very challenging system while you are doing your job, while you're raising your family, while you're doing all sorts of other things in your life. So there's a needless level of complication here that the ACA partly ameliorated in the sense that now you can't be discriminated. You don't have to go and get a healthy physical before you can get a health insurance policy. But on the other hand, it introduced a lot of complications that made things much more difficult to navigate.
So I kept cutting you off. Let me ask you the other way in which people are going to lose healthcare insurance through the one big beautiful bill.
Yeah. The other issue is, so there's the ACA, and then there's at least this important issue, which is the question of the cutbacks on Medicaid that are going in place. And the numbers that I gave before, the 16, 17 million numbers in terms of loss, are an amalgam of those two ways forward. One of the things that the ACA did that people aren't generally aware of is that it made generous subsidies from the federal government to state governments that expanded eligibility of Medicaid from just 100% of the poverty level folks to above that 133 or 38%. I can't remember right now. And a lot of states opted in to do that, but some states stubbornly and for no good reason other than I think spite decided not to do it. And that and some other changes that are in the One Big Beautiful Bill are going to make it very hard for a lot of people to remain on Medicaid. So it's that's probably the biggest, most immediate impact, even more so than the ACA subsidies, although that's going to be big too.
Yeah, so again, this is something that that I was going to say Biden, but yeah, actually this goes back to Obama, that they did expand Medicaid, but again, it was done on a state. Well, just to back up, I guess I should say it was originally intended to be done nationally, and then the Supreme Court said that they couldn't do it nationally. It's interesting how the president suddenly got much more power in the last few years with this, or last year, I guess I should say, with the Supreme Court. But when Obamacare was contested before the Supreme Court, they said that it was too, I forget the term they used, but it was overstepping the boundaries of the federal state jurisdictions for the federal government to dictate that Medicaid had to cover everyone in every state up to 138% of the poverty line. So it was an opt-in that states could opt to do that. They had very strong financial incentives to do it, and most did. Was it 10 states are still outstanding?
A little bit less now, but I think that's exactly right.
Yeah, so there's still some states that refuse to do it, but It wasn't an option to have it done at the federal level. And so the One Big Beautiful Bill reverses that increase. So was it back to 100% of the poverty line?
Yeah, that's what it would be. And there's a big gap between 100 and 133%, as we've seen, because there's a lot more coverage by Medicaid in states that have used the higher threshold. It brings in a lot of people that are then eligible for Medicaid, which is much less expensive than even trying to get your employer provided health insurance after your employer pays portion of it. But I think something that you're just saying, Dean, I think is really worth emphasizing. And again, I think the ACA is a flawed, incomplete, and disappointing policy in some respects. But there are a lot, and one reason is because so many of the things that are good about the ACA are, what I think people are called submerged state policy, things that you don't quite see and you don't associate with the ACA, and therefore you don't defend them. So the inability to discriminate based on pre-existing conditions, which was an extremely big problem before. It's in the ACA, but I don't think people fully recognize it. The idea that you can keep your kids on health insurance, your own health insurance policy, until they're 26 instead of 18 or 21 or whatever your insurance company dictated before, or 22. That's a big difference for a lot of young people. And the impact of the ACA on Medicaid through the 133% versus 100%. Those are things that we don't necessarily think of as the Affordable Care Act, because we think Affordable Care Act is the marketplace where you go and buy your health insurance. And relatively few people, relative to I think what people were thinking when the ACA went into effect, have actually taken advantage of that part of the ACA, which is the most visible part. There's a lot of other rules and regulations that make a big difference. that are under threat right now, and have made a big difference to people. Again, it's not the perfect policy. We could have done much better. A Medicare for all, or a whole bunch of different options that were potentially on the table. But I think it's worth defending, at least for the moment.
Yeah, I remembered after it passed, a few years after it had been in effect, there was a lot of people were attacking it, saying that not that many people were taking up the exchanges. And, I was looking at the data on that, and I won't claim any great expertise here, but I could look up the data. And it was true that the exchanges, so if you compared the projections, how many people they thought would be on the exchanges, it was somewhat less, so I'm thinking like 215, 216 thereabout. It was somewhat less than they had projected, but they actually had more people covered. And that was because you had an increase in employer provided insurance, because there were some incentives for employers to provide insurance to their workers. So the number of people, or at least percentage of people who are uninsured, was actually somewhat lower than had been projected. So it was hard to call that a failure, at least by my lights. I mean, the point was to get people covered, and you had somewhat fewer in the exchanges, fair enough. But those people were getting covered, again, mostly from employer provided insurance, as I recall. But, again, so it did advance that.
No, the share of people that didn't have health insurance before and after the full implementation of the ACA is, roughly been halved. Now, we still have a long way to go, and that's the problem. And it's not just who does and doesn't have it in the moment, as you were saying before. It's the fact that it's never quite certain. Are you going to be able to hold on to this if you lose your job? Will you be able to afford it next year after the price increases? There's a lot of uncertainty in that market, and the fact that it's a market is a problem in and of itself. So it's tough.
I'm going to mention one other thing in my plug for the Affordable Care Act. Again, looking at the projections from at the time it was passed and what subsequently has happened, healthcare costs have risen much less rapidly. In fact, they actually fell a little bit as a share of GDP, I think a couple of years ago. That hasn't been a general pattern, but we'd been seeing, of course, healthcare costs rise much more rapidly than GDP. There's increasing a share of GDP, and almost all projections expected that to continue. And it largely stabilized after the Affordable Care Act was passed, which was remarkable. Now, I couldn't sit here with a straight face and say that was all due to the Affordable Care Act, but it's hard to believe that at least some of that wasn't due to the Affordable Care Act. And what I always point out, because again, this is one of the things I yell at, the people who are political, the Democrats I know, the people involved in politics, I go, how come you guys don't take credit for that? And, I never heard Obama's people take credit. I never heard Biden's people take credit for it. I couldn't answer why. But, again, clearly all the slowdown was not due to the Affordable Care Act. But I always say, put the shoe on the other foot. Suppose there had been an increase in cost growth, and suppose it happened everywhere in the world. It happened in Germany, it happened in Canada, it happened in Japan. So it obviously wasn't due to the Affordable Care Act. They would have to eat that, because the Republicans would be saying it every single day of the week. But, here it was that, again, part of the success, I'm sure, was due to the ACA. Some share, maybe most of it was not. But it's a really great story, just in the sense that if healthcare costs had continued to rise at the rate they had been, or had been projected to rise, we'd see a much larger share. I'm talking about thousands of dollars per year per person going to healthcare costs. So that was a big deal. And, again, I'm not in a position to say what share that was due to the Affordable Care Act, but surely it was some of it.
Yeah. No, I think that's a very important point. There's also a flip side of that, which I know you're an expert on much more than I am, but the share that the U.S. spends on health insurance, health care in general, as a share of GDP, compared to countries that have systems that are much less profit motive oriented, that have a much smaller role for the private sector, or even very little role for the private sector. It's really a shame. I mean, given the amount of money that we spend, we ought to be able to provide not only universal coverage, we ought to be able to provide coverage to people that come from, Europe to, well, I'm not going to say anymore, but, we ought to be able to do that. And the fact that we don't, I think, is partly a function of the profit motive that we have introduced in this in a way that's very inefficient. And the fact that we have, 6 or 7 different ways of delivering healthcare. One of the most important roles for health insurance companies is to deny you coverage, because that's how they make their money. There's just a lot of perverse incentives and a lot of inefficiency and a lot of bureaucracy that is related to the private sector. And we see in countries that don't have that they provide as good or better health care, health insurance at a much lower cost. So it's something that we have a resource that we could bring to add on to what you're talking about in terms of the availability, the impact, the positive impact of the ACA on the cost control issue.
Yeah, I mean, the differences are incredible. We pay about twice as much per person as the average for other wealthy countries. So here I'm comparing this to France and Germany and UK. I'm not talking about very poor countries, which obviously spend much less on healthcare. But these are countries that are comparably wealthy, and in fact, they actually have better healthcare outcomes than we do. Again, that's a complicated story. So it's not just what they spend on healthcare, but it's not as though other people aren't getting decent healthcare. They clearly are. So let me ask you, I'm going to put you in charge. We had the one big beautiful bill. So now we have the John Schmitt, and we could, if you want to implicate Emma on this, you're welcome to do so. But what would you like to see us do going forward? Assuming we get a somewhat change in political sentiment here.
Well, I mean, there's a two-step. First of all, don't ever put me in charge of anything. But separate, if a gun to my head, I think in the short term, the obvious issue is to, stop the bleeding, to reverse, to stop doing the bad things that we're doing right this second. I mean, if all we could do is turn back time and it be December or October of last year, when none of this was exactly on the table in the current form, I think we would be in much better shape. We've had an enormous increase in enrollment in the ACA. We've had solid improvements in access to Medicaid, and the number of states that have accepted the Medicaid expansion has been increasing. So at the very least, if we could just return to where we were and work piecemeal, we would be in better shape than we are right now. Now, that said, I think the real solution is to take a step back and figure out how we can migrate from the system that we have to something that many folks have been talking about for a long time. And we've used the term single payer, Medicare for all. And I know you had a guest on earlier on in this series that talked about that. And I think the kinds of solutions that you talked about in that particular program are the kinds of things that I would lean towards as a solution. Just taking the profit motive out of this, providing a service, not making it dependent on pay. As somebody recently said, I don't have to, it's not fee for service when the police or the firefighters come to, deal with a problem in my neighborhood or an issue in my neighborhood. We don't expect that people pay tuition to go to public grade school and high school. So I just think there are a lot of ways of organizing an economy that are more efficient. And in particular, for something like education or healthcare, the market mechanisms are not the best.
Yeah, the person you referred to, Adam Gaffney, who'd worked with physicians for a national healthcare plan. So yeah, he's been a longtime advocate of universal Medicare, single payer, however we call it. Yeah, just to emphasize a couple of the points here. I mean, we were talking a moment ago about how we pay so much more. Much of that is we pay about twice as much for everything. So prescription drugs, we pay about twice as much for our drugs as people do in Europe and Canada. Our doctors get paid about twice as much. I have friends who are doctors. They don't like me to say that, but that is the reality. Doctors shouldn't be poor, but they don't have to necessarily get quite as much money as they do. And I'll just, again, clarify, that's mostly the specialists. So it's not that our primary care physicians are so hugely out of line. It's, the higher paid specialties, cardiologists, neurology. Though many of those people are paid hugely higher than their counterparts in Germany and France. So we pay much more for our doctors. Medical equipment, again, MRI machines, you go down the list. Again, you look at, MRIs are tremendously expensive here, half price or less in Germany or France. I mean, just crazy what we pay for these things. And, that's a longer story. I won't go into everything here, but that's much of our difference in cost. The other huge factor is exactly what we've been talking about, that we have this hodgepodge healthcare system where we have, insurers, we have people monitoring the insurers, pharmacy benefit managers. Again, that's not the main reason healthcare costs, drug costs are high. It's that we give drug companies patents and they charge whatever they feel like. But pharmacy benefit managers, why do they exist? We don't have food benefit managers. It's just, total waste in the system. Yeah. So, we can And ideally we'll have a time where we could talk about moving to Medicare for all. Again, it's not the sort of thing you could do overnight, but, I'm not gonna say I got a lot of encouragement from, the developments we've seen in healthcare under the Trump administration. But the one thing I will say I get a little encouragement is it does show the possibility of moving big. And, there's been an idea that we have to, which I bought into, I'll say, that we have to move very incrementally. And again, I don't think you can do it overnight. Just to be clear, it's not that we're going to get, whoever is president in Congress and, the next January, we're going to have Medicare for all. But you can talk about moving to it, to my view, in a reasonable time frame. So, but again, that would be a different world.
Yeah. We'll see.
So are there other things from your work that we should get to before we call it a day?
I think we covered a lot of stuff. I would just say, to preview the next bit of work we want to do is look at just how expensive it is for people who do have health insurance when you consider what they need to pay in terms of the premiums, what they're paying in terms of deductibles, what they're paying in terms of co-pays, what they're paying in terms of uncovered costs because they're denied by their employer, the amount of medical debt that people are in. And I think you could translate those into some sort of tax terms, how much more in taxes will we have to pay versus how much more in all of these kinds of unexpected and difficult to navigate kind of costs. We have a very, very expensive system, not just for people, not just compared to GDP, but for the individuals who are participating in the program. It's a total mess, and we need some big solutions. And I like the idea of going big to the extent that we can.
Yeah, that is an important point that I think can't be emphasized enough, that it's an incredible toll on people's, time and their psyche. I mean, again, most people thankfully are generally reasonably healthy most of the time, but that's not what you need your healthcare system for. You need your healthcare system for the people who have health issues. And naturally, insurers don't want to pay. And, again, thankfully, I'm generally in the reasonably healthy group, but the few times I've had claims, they've generally been small ones. I almost invariably, I'd say probably half the time, I've had to have an argument with an insurer, and it's not like something like physical therapy, that just to give people an idea that and it really is just an oversight. It wasn't that they're not, it's questionable whether it would cover the physical therapy. It just, there was some oversight. They messed it up. They were charging me a bill that I didn't have to pay. And, again, I could deal with it. I have a PhD in economics. I know how to read forms, but it's just a waste of people's time. And again, for people who are in bad health, people with a serious medical, it's just not what you want to have. And it's unfortunately, a really big part of the story with our healthcare system.
I think the hidden costs in terms of bureaucracy, the hidden costs in terms of over and above whatever the premium you pay, all of those things should be enough to create a consensus that we can do things differently, we can do things better. And unfortunately, it's just going to take a lot of pain and suffering, it seems, before that coalesces into something where we feel like we can move forward and change the system. And as you said, it is the case that the Trump's kind of move fast, break things, Silicon Valley approach maybe gives us some imagination to think about, the fact that things can happen quicker and faster, and obviously with a lot less pain and suffering than he's inflicted. So we'll see.
Well, thanks a lot for coming on, and I enjoyed the discussion.
Well, thank you. It's great to be here. Appreciate it, Dean.
If you like what you just saw, please help us out by liking us and subscribing. Thank you.